Well, good afternoon, good afternoon, good afternoon. Let's all, if you look to the person to the right and don't talk to them, and then the person on the right, look to your person on the left and don't talk to that person, then we might be able to get started here in a few minutes. Well, I want to first thank you all for coming out this afternoon. We appreciate all the work that all the organizations deal with in the healthcare community, in particular in the minority communities of colors across the country. I want to say a special thanks to Dr. Puckering and Gretchen and their leadership team for pulling this together. I believe this is the 14th annual Leadership Summit. So again, welcome and the work that you all do out there in the community. My name is Elroy Saylor. I'm a father and I'm a husband. Those are my titles. I work on Capitol Hill, spent some time in the Senate and on the House, and spent some time on the Trump transition team and on the campaign and at the RNC for a while. So again, it's a privilege to be here for National Minority Health Month. Again, let me just welcome you all to the National Minority Quality Forum 2017 Leadership Summit and Spring Health Disparities. Think for a moment it's Monday today, April 24th. It's National Minority Health Month. Today, Congress and the new administration, they're going to take another look at the Affordable Care Act. We've been looking at this Affordable Care Act throughout the entire Obama administration and through the first 100 days. It's a major piece of legislation, as we all know. The ACA, it impacts pretty much everyone in our country and impacts just about every facet of the American healthcare system. Many policymakers, on one hand, some say it's too hot, and on the other hand, some say it's too cold. That's what we've got right now in Washington, where some say it's too hot and some say it's too cold. Well, Dr. Puckering has invited a few of his friends here today, and thank you for being here, to join in on a very special discussion that's going on. It's actually going on right now. There's a discussion going on between folks from HHS, individuals from the Congress, individuals from industry, and individuals from the nonprofit sector. And because of Dr. Puckering's leadership, we're going to have an opportunity to be a fly on the wall. I sat in the Senate, I sat in the House, and I've been a part of discussions with the administration. I've been a part of discussions with governors, and I could tell you sometimes that process is not pretty, making sausage, but at the end of the day, when we get enough reasonable-minded and like-minded people around the table, we can end up doing some good things for our communities, in particular communities of colors and underserved communities around the country. So right now here in Washington, D.C., there's an important meeting going on. You know, the folks at that meeting include the Carol Jimenez, the acting director of the Minority Office of HHS. Carol has served in Washington, and you wouldn't tell by looking at her, but she served in Washington for over 30 years of experience, expanding access to high-quality, affordable health care for the vulnerable population. Right now in that meeting as well, you also have Alan Ryan. Alan Ryan is one of those graduated summa cum laude. I graduated thank you cum laude. And this guy has a RPH, an MBA, an MA, an MDIV, and you know, he has a PhD. I have just a PhD. So I'm fortunate enough with my PhD, but we're very fortunate to have Alan representing Novartis and Sandoz with us. Alan serves as the director of U.S. Advocacy and Alliance Development for Sandoz. It's a division of Novartis. In that capacity, he leads, he's also a pharmacist who's worked in retail, HMO, long-term care, and special pharmacy settings. So we're pleased to know that Alan Ryan is in that meeting as well. Thirdly, in that meeting, interesting enough, you have Dr. Christy Gamble, who actually received an award or will be receiving an award. I don't know if I let the cat out of the bag, but she's receiving an award here this weekend. But you all are probably familiar with Dr. Gamble. Dr. Campbell runs the Black Women's Health Imperative effort. In that capacity, she works with communities of colors throughout the country. So she's a part of that very important meeting. You know, you can't have these meetings in Washington with just folks from the White House and the administration and industry and folks from the nonprofit. You also have to have your friends over in the Senate and your friends in the House. So Dr. Puckering was smart enough and wise enough to say, hey, you know, if they're going to have a private meeting, we want to make sure that Senator Scott's office is represented. He's been a leader on this issue, and Kate Hunter from Senator Scott's office has joined, and she's in that private meeting that's going on right now, talking about these important issues. Can't forget our friends in the House, Congressman Slaughter, Congresswoman Louise Slaughter. Her staffer is here, Colleen Bell. Colleen Bell has spent a considerable amount of time on Capitol Hill, also working for Senator McCoskey. She's a graduate of Ohio State University and is focused on women's health care issues as well. The last person in that meeting is on the House side is Charlotte Pineda. Charlotte is from Representative Fitzpatrick's office, and she's here with us. She spent some time with Orrin Hatch working on health care issues. So that meeting is going on right now, and we're gonna, I don't know if Dr. Puckering is still in the room, but let's just see what's going on in that meeting. We got to be real quiet, though, because this is a closed-door meeting, and if we're quiet enough, they may allow us to ask some questions. So let's walk on over to this little kitchen table. Let me get in the room. I think the acting director at HHS is probably speaking right now.
Good morning, everyone. It is so nice to be here with you. And on behalf of Secretary Price and myself, Secretary Price and I really appreciate the invitation from Dr. Puckering, Gretchen Wortman, and Elroy to be here today and to speak with all of you. You know, the National Minority Quality Forum is such a key organization, and you're all key stakeholders to the conversation. And Dr. Price, certainly in my conversations with him, has conveyed that he understands the importance of reducing health disparities and working with the stakeholders representing racial and ethnic minorities to improve health for them and people around the country, and that he looks forward to continuing the conversations that the department has had with the forum and with all of you. So, as Elroy said, I am the acting director of the HHS Office of Minority Health. I look around the room and it's nice to see familiar faces, and I look forward to meeting the rest of you after this session. Many of you know that the Office of Minority Health has been in existence since 1986, so this is our 31st anniversary. And our focus is on improving the health of racial and ethnic minority populations throughout the country. It's especially relevant that this conference is being held during National Minority Health Month, and especially relevant in the confluence of themes. The theme for this nation's Minority Health Month is Bridging Health Equity Across Communities, and the theme of the conference also has to do with building sustainable, healthy communities and creating data-powered alliances. So, along with that theme, I wanted to just mention briefly a couple of initiatives that my office has been working on behalf of HHS. And before I do so, I want to just take a tangent for a moment and introduce a couple of my staff who are with us today. Dr. Andrew Sanderson is, Andrew, do you want to stand up so people can see? Dr. Sanderson is our medical officer at the HHS Office of Minority Health, and Enrique Fernandez is our legislative analyst. And both are here for the duration of the conference and are also happy to answer any questions or take down any issues or concerns and report them back, and we will get back to you. So just really briefly, a couple of initiatives that you all might be interested in given the theme of this conference. We have worked with the National Center for Health Statistics on a NHIS survey of Native Hawaiian and Pacific Islander population that was released in March, earlier in March, and it's the first time in this country that we have disaggregated the data for the NHPI population, really a huge step towards being able to concretely identify the disparities and try to address them for those populations. And the data is available in a public use file on the NCHS website, and further disaggregation of the data is available through the resource data centers that are scattered around the country. If you want help in accessing it, just let us know. Also, we are co-sponsoring with CDC a tribal BRFIS oversample. And so we are working with 11 states that wanted to participate in this to collect sufficient data to really identify, again, health disparities within the different tribal communities. And when that is done, the data will be shared with the tribal epicenters as well as being made available, and through the tribal epicenters will be made available to the tribes who participate in that research. And then we have a couple of community data projects. We are working with a couple of communities and states to pilot community-driven data collection and to pull it into a centralized source and to help teach communities how to use the data to help them address disparities. So we have a lot going on. I'm looking forward to hearing what the issues of interest to you, any concerns that you may have, and Dr. Price has asked me to take notes and report back to him what's being said, so I look forward to doing that.
Good morning. Good morning. Is that working? You can hear me? Okay. So my name is Alan Ryan. I work for Sandoz, a Novartis company, and we are delighted that, frankly, the Biologics Price Competition and Innovation Act, the subset of the ACA, did not get drawn into the arguments that were going on about ACA on the Hill this year. So we're pleased that essentially everything is continuing to move forward as it pertains to the next wave or next opportunity of increasing patient access for patients, including patients in minority populations, to biologic medicines. So if you don't already know, essentially, the Affordable Care Act included a provision that allows the FDA to create off-patent copies or follow-on biologics called biosimilars. And so that's something that Sandoz, being the second largest generic manufacturer, is in the process of making. We are the global leader in biosimilars, and we are part of Novartis. And so that is something that for us is a key initiative to increase patient access through the increased competition that comes along with providing of these biosimilars. So we are excited that the FDA is also doing a lot to educate various populations about what biosimilars are. When generics were first launched, there were patients that were concerned about, is the generic as safe? Is it essentially the same as the reference brand? And long story short, those same kinds of concerns are the concerns being expressed today about, will a biosimilar be as safe? Will it be essentially the same as a reference brand biologic? And so the FDA is taking steps, fortunately, to do education for patients and for providers to make that assurance. And so we're excited that it's happening because they are the experts on actually approving the product, so they can be the most neutral as far as education on that topic. And there are some other areas that we do need to continue to work on. For instance, CMS has still not fully addressed an issue as it pertains to the reimbursement of biosimilars that was raised in 2015. And so that is something that we're continuing to have an ongoing dialogue about. But that reimbursement issue, as we know, that even if you have a good product, if the reimbursement doesn't work, then ultimately the system won't work to provide the competition needed to have the access that is desired to get the savings ultimately that we all want as taxpayers and as consumers. So.
Hi, my name is Christy Gamble. I am the Director of Health Policy and Legislative Affairs at the Black Women's Health Imperative. We are an organization that seeks to improve, or we work to improve, the health and well-being of the nation's 21 million Black women and girls. And we envision a world and a nation where Black women and girls are able to live their most creative and productive lives free of any limitations associated with poor health and wellness. And so I'm very honored and grateful to be here today, specifically with representative from Dr. Price's HHS office. So for the Black Women's Health Imperative, we recognize that historically people of color have experienced significant barriers to accessing quality and affordable health care. And because of that, we made one of our primary healthcare policy priorities accessing affordable, quality, innovative, and comprehensive healthcare, and that includes access to affordable and innovative drugs, prescription drugs such as biologics and biosimilars. Unfortunately, biologics have come onto the market at an extremely high price, which have priced these drugs out of the reach of populations that need it the most. And unfortunately, people of color are disproportionately impacted by a lot of the chronic conditions that these drugs would treat. So we at the Black Women's Health Imperative seek to be a part of the conversation to make sure that people of color have access to this, these drugs so that we can help to improve the health of people of color as well as reduce racial health disparities, which we're currently seeing today.
Hi, hope this is on. I'm Kate. I am a policy staffer for Senator Tim Scott. And I think that policymakers, patient groups, and constituents in general have been really excited for years over the promise of what biosimilars can do, particularly for minority communities. These drugs, of course, have a lot of promise to treat illnesses that disproportionately affect the minority community, including cancer, diabetes. But unfortunately, we haven't seen that promise realized to its fullest extent yet. So I'm really excited. We have a couple of things going on, at least in the Senate, that could improve the ability to have greater access, expand access to biosimilars. This includes the reauthorization of the FDA Reauthorization Act, which includes agreements made for biosimilar user fee agreements, and these fees obviously go towards helping the agency to review applications for biosimilars. So this is something my boss is particularly excited about as a member of the Health, Education, Labor, and Pensions Committee, having an opportunity to improve this process, to strengthen and streamline the review process for biosimilars, and hopefully to expand access to these innovative technologies and these great therapies.
Sorry, I just don't know how to turn this one on. Hi, my name is Charlotte Pineda. I'm the legislative assistant to Representative Brian Fitzpatrick, Bucks County, the suburbs of Philly. So why congressional staffers are here? The primary motive, at least here in the Republican office, is to try and address market failures. The truth lies that biosimilars, biologics, are very expensive to do. It's cheaper if you look at R&D spending to create a lifestyle drug than a life-saving drug. And the overall R&D costs have been increasing over time, more notably Alzheimer's disease. Merck recently had their second failure on phase 2. But you also see companies trying to address market failures by taking innovative risk approaches. So again, going back to Alzheimer's, you see companies merging together. Biogen has partnered with one company, Merck had partnered with another, and there's one other in the drug development process. With regards to the UFAs and what we can do to streamline it, while it will take a period of no less than 7 to 10 years to really see a policy into effect. More notably, the Orphan Drug Act passed in 1983, followed by Genzyme getting approved as under the Orphan Drug Act to treat a very rare disease that affects 10,000 people worldwide. So when we have this discussion, I want us to be able to talk about the policies that can streamline the drug development process, more notably 21st Century Cures, providing $500 million over a period of 10 years, and also the FDA commissioner streamlining the process to reduce that administrative burden and try and help decrease that 10-year period that it takes to go from basic clinical research to finally going to USPTO to get your 7-month review, to get that patent, build the facility, and take the drug to market.
Hi, my name is Colleen Bell. I'm a legislative director for Congresswoman Louise Slaughter. Congresswoman Slaughter's been in Congress since 1987. And when she started working in Congress, it was brought to her attention that clinical research was being conducted on a breast cancer treatment that was only being conducted on men. And she has made it her lifelong crusade since coming to office to diversify clinical trials and access to clinical trials. The other part of biosimilars and biologics is that they have to be tested on populations to approve their effectiveness for certain conditions. And we have a real continued lack of diversity in the clinical trial setting. And so one of the things that she's really worked for and has fought for during her career is to try and continue to diversify clinical trials to make them attractive to people who want to participate in them, but also to push pharmaceutical companies and the FDA and the NIH to include minority populations when they are testing new drugs. So I think I just wanted to sort of talk about the flip side of biologics and biosimilars, which is that they only come to market after people are willing to participate in clinical trials that can prove their effectiveness and their safety for the condition that we're looking to address.
Well, folks, we're in the room. We're having a great discussion here. As you all know, the president took on a Herculean task, President Obama, of trying to ensure that all Americans could have access to health care. Part of that mammoth bill, which was over 3,000 pages, a very small part of it focused on exactly what these women and men are talking about here at the table today. But more importantly, when it comes to our communities, sometimes, it's not lack of knowledge, it's not lack of resources, or it's not lack of will. Sometimes it's just lack of getting the information from Washington. I'm from Detroit, or getting the information to Atlanta, where I went to school at Morehouse College, or getting it out to Compton, LA, where many of my family members live. So, Christy, you're there, you're in the nonprofit community. What specifically is it, where are you seeing the biologicals that have the most tremendous promise for our communities? I mean, I'm not really a total understanding of biologicals, and I'm sure everyone in the room does, but just in layman's terms, where is the promise?
Right. As I mentioned before, there are several diseases that seem to impact populations of color disproportionately, and biologics have proven to be a great innovative drug to treat some of these conditions. One major one is breast cancer. We know that Black women are 41% more likely to die from breast cancer, and they have a more aggressive form of breast cancer. So there are certain biologics on the market, such as Herceptin, that will treat breast cancer. Also, another condition will be lupus, and we know that women of color, Black women, Hispanic women, this is a common disease for them, and so there are certain biologics on the market that will treat lupus. Another very common disease that impacts people of color is diabetes. We know that over 27 million Americans suffer from diabetes, but unfortunately people of color are more likely to develop diabetes, and they're more likely to have worse treatment and not be able to manage their condition and see a lot of severe complications. Gratefully, there are biologics on the market, such as Lantus, that have become a mainstay in treating this disease. And then we have multiple sclerosis, which we now know that Black people are 47% more likely to have a diagnosis of multiple sclerosis, and they're also more likely to have complications from the disease. But there are biologics on the market that have proven to be very helpful in treating multiple sclerosis and psoriasis. Lastly, I won't talk too long, but psoriasis, we didn't think that was common in people of color, but we now know from research that it's a very common condition. And unfortunately, because it hasn't been seen as very common, and it's very difficult to recognize psoriasis in people of color because of the darker skin tone, there's been a delay in treatment. And so that means more complications from psoriasis. And many people of color have said that their quality of life has decreased because of psoriasis, but there are luckily some biologics on the market that have proven very well as treatments for psoriasis in people of color.
Thank you very much, Christy. Like I said, I've been in Washington for a while, and On the right wing, you've got a lot of my colleagues who'll say, we want a government so small that you can't see it. And on the left wing, we have many of my colleagues and friends there that say we want a government so big that it does everything. Well, as I said earlier, there's kind of a happy medium, and I think, you talk about the right wing, you talk about the left wing, but what we forget in Washington is the bird in the middle. That bird in the middle, you need Washington to provide oversight. There's got to be some form of taxation. There's got to be some ability to have redress and litigation and things of that nature. So that gets you to the FDA. The question that I think we would like to address to our congressional staff is what role, as Congress over the next 2 weeks continues to debate the American Community Renewal, I did tax credits last week, as they continue to debate the Health Care Act, what role do you see FDA playing to ensure that patients are experiencing the full benefits of biosimilars?
Sorry. So as I mentioned earlier, I think apart from the overall discussion on how we reform the current state of healthcare in the United States, I think a big role that Congress is playing right now is obviously reauthorizing the user fee agreements, and the FDA's role in that process and helping to ensure that there's greater access to biosimilars is to create a level of certainty for developers. Right now, the review process for biosimilars is very, very new. And so being able to provide a more streamlined approach to finalize guidance on certain issues that we know are important for the industry, like labeling and naming requirements, as well as interchangeability. If the FDA can provide some certainty in those areas, I think that we can see an uptake in interest from developers in kind of getting in and starting this process and developing biosimilars and trying to get them to market. And I think the more biosimilars we have on the market, the greater access we'll have to those who are fighting these diseases. We saw in Europe, after the first biosimilars were approved in 2006, Europe now has 21 biosimilars on the market. And as these drugs have been approved, we've seen the cost of biologics go down on average 30%. And in at least one case, the cost of a biologic with the introduction of a biosimilar went down 60%. We only have 4 approved biosimilars on the market right now. So I think that if the FDA can provide a better certainty in this process and how this goes and improve communication with the industry, we can hopefully see more biosimilars on the market and improve access.
We now have 5. They approved one this past weekend. Remicade, I believe is the name. The current state of the FDA, and with your question, you were referring to the Biologics Price Competition and Innovation Act. So just moving it forward, while it was a monumental step forward in addressing the lack of the inefficiencies and addressing a market failure. Pharmaceutical manufacturing, you look at McKinsey, you look at Deloitte reports, it's not an attractive market to really be. And if you look at the return on investment and the average amount of years it takes, Merck had a huge hit when they failed phase 2 of their clinical trial for Alzheimer's. And while you don't really see a lot of failures in pharmaceutical manufacturing being advertised, it's huge. You just look at the SEC filings for Pfizer and looking at other companies. So you see a lot of consolidation because of these failure rates. The BPCIA is much like the Hatch-Waxman Act, meaning like Hatch-Waxman aimed to increase innovation in generics, and there was a response to it. But now what we're seeing is all of these diseases that, rare diseases, diseases that are easily preventable, like diabetes type 2, because type 1 is indiscriminate. FDA right now is working on, provided under 21st Century Cures, to implement provisions in Title III to really streamline that process more quickly and effectively. So it's an add-on to BPCIA. It also establishes a review at FDA, what Colleen was talking about, on biomarkers and other drug development tools that could be used to shorten that drug development time. As the years have been increasing in the drug development process, congruent at the same rate, so has cost. So while these are very intricate diseases to address, the more important line is decreasing the amount of time that it takes to get it from basic clinical to USPTO to market. And of course, this is not just an isolated approach. ASPE, one of the research arms over at HHS, had a review of prescription drug expenditures within a 30-year time period, and they attributed 10% to population growth, and then 30% for each, both on increased cost per person, and then increased cost per person, economy-wide inflation, and changes to drug composition, and just drug companies just marking up the price. And then you get a little bit more intricate there. But I'm going off on a tangent here, but what FDA should be doing is really streamlining the process as much as it can, while HHS should focus on, and the patent office should be focusing on other failures that increase that 30% cost and how drug companies react, whether it be proprietary agreements, inter partes review, et cetera.
Covered a lot there, so between the two of you. I was just going to mention, one of the other big things that Congress has, which is our oversight role. Kate talked about things that are going to be going on in the Senate Health Committee. The FDA nomination is going to be moving through this week. I think it's really an opportunity for Congress to exercise its oversight role and capacity to sort of prod along various policies and procedures that will make the FDA more effective at the goals that they're trying to accomplish. And I think the other thing is, how does Congress continue to set up a system that incentivizes drug makers to look at orphan and rare conditions that may not be as fiscally attractive to them, but affect a large population. And we have so many conditions where there hasn't been any new drug development in those areas in 30 or 40 years, and sickle cell anemia is a classic example. How are we getting drug manufacturers to put drugs in the pipeline, and how is the FDA's role in making that an attractive proposition to pharmaceutical companies, something that Congress can help move along? So I think that's another important role that we play as well.
As a small businessman, and that's not because of my height, that's because of my revenues, I'm always trying to figure out a better way to get a product and get it to the marketplace, and how do you deal with a marketplace, and how do you deal with Congress. But one of the most important things I've learned as a businessman is to look at other businesses, whether it's in another city or whether it's in another country. Alan, we're sitting here with some senior representatives from the Senate and the House, and your Secretary Price is top person here. As an industry expert, you look at Europe. I believe, Kate, you mentioned Europe and some of the experiences they're having in Europe. From a business perspective, what can we learn from the European model? What would you tell our senior staffers to tell their bosses, or what would you tell Carol to tell Dr. Price as it relates to the next few weeks as we go through the discussions here? What's working, what's not working? How does it make sense to I think we're at 50.2% minority population? Is that 50.2% of the minorities who live in this country?
So that's a good question. So first of all, in Europe, they've had biosimilars since 2006. So it's 10 years prior to when we first had our first biosimilar approved and put on the market. Biosimilars in certain markets now are the market leader as far as the volume of drug being used for a particular condition, because they are less expensive because of the competition. That being said, as recent as 2 years ago, there was something written in Europe about how physicians and patients both needed to still have yet a higher level of education and understanding about biosimilars, because essentially people need to feel confident that what they're getting is essentially the same and just as safe to take. So that was something that, even after being in the market for 10 years, that the Europeans felt needed to continue, was education about biosimilars in Europe. Now, something that doesn't necessarily as easily translate is the reimbursement matter, because in Europe, they have a different system of reimbursement. We'll just leave it at that. And so here, our reimbursement system essentially needs to provide the right kind of mixture and incentive for all stakeholders to use biosimilars and increase the competition in a way that allows the market to actually work. And so something that was done, at least as our read of the initial biosimilar reimbursement, was that each biosimilar would have what is called its own J code, which is a reimbursement code, its own unique reimbursement code. And then that would allow the biosimilars to compete one versus another rather than being all lumped together into one common code amongst just the biosimilars, while the reference brand has its own separate code. And you might say, well, what's the difference? Well, if you're in a physician's office, if they're using biologics and they know that they're going to get a standard rate of reimbursement for the reference brand, because the reference brand product reimbursement is standard and never changes, and then you have a biosimilar reimbursement rate that changes because there are multiple products in it, so that can change the rate, then which one are you going to use? Well, you're going to go with what you're certain of, right? You're not going to buy an expensive product for you to put into your inventory as a physician, and then possibly, if the reimbursement, because it's blended or there's a grouping of multiple biosimilars in one code, if you have that mechanism cause that physician to get reimbursed less than what he paid for the biosimilar, then he's not going to use it going forward again. I mean, that's just as simple as that, right? So that the certainty versus uncertainty part, I wish that would be something that we would tackle, and that's something that has been pretty aggressively communicated to all the appropriate parties, to say this is something that we think is really a linchpin that needs to be changed to make the biosimilars market work.
Thank you, Alan, for that. Again, when you look at our poor black, red, and yellow, and brown communities across the country, one of the things that, I've seen as I've traveled the country, of course, America's the greatest place in the world. We can put a man on the moon, you can sit in your couch and turn your TV on these days. It's a pretty amazing place. But one of the reasons we can do all of these great things is because we do have a federal government that provides some level of, I don't want to say credibility, but provides some level of consistency, making sure that things are safe that go to the marketplace. Dr. Gamble, you're there, you're in the community, you've worked on Capitol Hill. One of the things that, I would like for you to share with our staffers and Dr. Price's office, Secretary's office, is, how do you think and what role do you think FDA has as it relates to safety? What have you experienced over the last 8 years or over the last 12 years in terms of the FDA making sure that, first and foremost, this new opportunity that we have before us is safe? Because again, when you go back to underserved communities, sometimes there's a fear of the unknown or a question of safety and concern, and to the extent that the federal government, through the FDA, through Dr. Price's office, and through the work that the staffers are doing via legislation, just what's been your experiences with FDA and the safety of these new products?
That's a good question. I think there's a balance that we have to play here when trying to get biosimilars or biologics and biosimilars to the market, to make sure they get there quickly, but we also want to make sure that they're safe and effective in the population. So we do believe that the FDA is doing a fairly good job at making sure that safe alternatives are coming to the market. And we already know that over about a third of FDA approvals have been biologics, if I'm correct or not. And we were very pleased when the Biologics Price Competition and Innovation Act was a part of the ACA, and it provided an expedited pathway of approval for biosimilars, which is a more affordable and a safe and effective alternative to biologics to the market. And I know there were a lot of concerns about this expedited pathway, but in talks with the FDA, it is still a safe route. Biosimilars have to go through, biologics and biosimilars have to go through safety and efficacy trials, and they have to be deemed as safe and effective by populations. But for us, we just want to make sure, for populations of color, we want to make sure that the drugs are getting to the populations that need it the most, but we also want to make sure that FDA takes in consideration that these are new drugs, they're innovative drugs, and to make sure there's not a one-size-fits-all approach when improving these drugs, because of the complexity of the drugs and the different treatment responses, particularly in people of color, that we notice with brand and generic. So we want to make sure that's taken into account. We also want to make sure that adverse events are actually logged to know which biologics and biosimilars are effective and what their reactions are in populations. But overall, we've been seeing improvement, and we're pleased with how the FDA is really moving forward with biologics and biosimilars.
Well, we said we were going to let you all join in on the conversation, and we're looking at our time. I want to make sure we get an opportunity for you all to hear from some of the participants. So we have a few minutes, and why don't we go from the left to the center to the right, my left, which is your all's right. Do we have any questions on the right side of the room over here for our staff? All right, speak now, forever hold your peace. I'm going to move to the center of the room. Any questions from the center of the room for Dr. Price's office or any of our staff? Here we go. Your name, sir, and answer your question.
Good morning. My name is Derek Robinson from Chicago. Question is for Acting Director Jimenez. Can you offer us any insights regarding the future of the Office of Minority Health under the current administration and Secretary Price?
Thanks for the question. The Office of Minority Health has been in existence since 1986, as I mentioned at the beginning of my remarks, and has been statutorily authorized since 1990. And we have no reason to think that it will not continue, or we are moving forward with the work that we've been doing. We're moving forward with new initiatives, and we have every reason to think that the work of the office will continue, as will the work of the other offices of Minority Health and National Institute for Minority Health and Health Disparities.
Any other questions in the audience? All right, well, we want to take a few moments and just thank our panelists for their time. Carol with Dr. Price's office, thank you for coming, and tell the good secretary I said hello. The rest of our panelists, Dr. Gamble, we want to thank you. I'm sorry, Kate Hunter. We'll go with the Senate's. We want to thank Kate from Senator Scott's office. Thank you. And Colleen with Congresswoman Louise Slaughter. Thank you. And then Charlotte with Congressman Brian Fitzpatrick's. Thank you. And Dr. Gamble, thank you very much. And then Alan from the private sector. Thank you. Well, again, thank you all very much. We hope that this session was informative and that you all learned a little bit of, I know I learned a lot. So again, thank you all, and enjoy the rest of your leadership session here. Thank you.